NCLEX review for brain dead, neurodivergent, and burnt out as fuck nursing students. Prioritize. Do not forget Maslow's hierarchy of needs, because these will be the questions where physiologically the patient is okay, but we have to look at safety and comfort as well as psychological. Rarely will we ever get to the last three portions of the fucking pyramid, but let's review. Physiological are your ABCs: temperature, cognition, changing cognition, blood glucose. And then we have the safety: risk of suicide, risk of falls, comfort. So Mark explains the difference between physiological and comfort is whether or not you can see it as the examiner. So the patient feels nauseous, keyword feels. There's a difference between vomiting and feeling nauseous. Vomiting is a physiological response, and feeling nauseous is a comfort issue. So here we go. Physiological versus comfort. Physiological, we have the objective information, such as vomiting, ataxia, staggered gait. That is the first priority. Comfort is subjective, such as nausea, dizziness. This is a third priority. So some examples of physiological problems include electrolyte imbalance. Safety would be a fall risk. Comfort would be pain and left fractured wrist. Psychological being denial. Social being homelessness. And spiritual hopelessness. Denial. What is denial? Denial is a river in Egypt. My apologies. Denial. The number one problem in any type of abuse is denial. This is true for any abuse, such as child abuse, substance abuse, gambling, and domestic abuse, etc. Denial. Denial is defined as the refusal to accept reality of the problems. I am not an alcoholic, I can stop whenever I want, and I am not an abuser are some examples, because this person is refusing to accept reality. How do you treat someone who's in fucking denial? Well, you confront them. How do you confront them? By pointing out the difference between what they say and what they do. The first step in treatment is for the patient to recognize and accept their behavior. For example, a patient may say, I am not an alcoholic, but the nurse's job is to point out the reality and the difference between what they say and what they do. So we're going to confront them and say, patient says, I'm not an alcoholic, but you say, okay, you're not an alcoholic, but it's 10 fucking a.m. and you've already had 6 fucking packs and a bottle of wine. Damn, that's a lot. And hopefully that hits the person and they realize the reality versus what they're saying and doing, their inappropriate addictive behavior. Another example is, I am not an abuser. Okay, well, you say you're not an abuser, but your wife has a fucking restraining order, that's spelled incorrectly, that says retraining. Your wife has a restraining order on you, and you're not allowed within 10 feet of your fucking children. Damn. That's really shocking. So that's confrontation. Confrontation is not the same as aggression. You do not attack the person. A good answer has I, a bad answer has you. This is generally good for actual clinical skills, by the way. A good answer has I, a bad answer has you. When is denial okay? Denial is okay in grief and loss. There is generally multiple ways to look at grief and loss. I went with the 5-step because I think that's what we use most often in nursing. And grief nowadays is considered to be flexible and very individual to, very subjective and personal to the individual. they don't follow this sequence. A person can go forward and backwards and stay in a period of, any of these stages, and it can even become a complicated disorder. So we have denial, which is the avoidance, confusion, elation, shock, and fear. Anger, which is frustration, irritation, anxiety. Bargaining, overwhelmed, helplessness, hostility, and flight. Depression, struggling to find meaning, reaching out to others, telling one's story, and acceptance, exploring options, new plans, and moving on. So denial would be saying, it's oftentimes for many people like the first few hours, first few minutes of an accident. So no, that can't be my husband who died in a car crash. It can't be him. And then anger being, why the fuck would God do this to me? Why did this happen? Why was the drunk driver on the road? Which is a valid question, by the way. Bargaining would be like telling God, I wish I could take my life for his. Please just bring him back, and I promise I will be good forever. Depression, honestly, goes along with all of these, but the depression may worsen to suicidality, which is always a concern. And acceptance is accepting that this person is no longer with us and you can continue life without them. If we are with patients who are in denial, our job is to support these patients. Don't try and confront them. And I fear that some of you will not already know this. We have to allow denial and grief and loss to continue. The stages of grief and loss are DABDA: denial, anger, bargaining, depression, and acceptance. Don't disregard the small details like this, because it definitely could be a really simple question that fucks you over in the long run on your HESI and NCLEX, because you didn't study it and you thought it was a simple problem, but it's always the things like this that screw you over. And I've had those 1,000 times. The hardest questions aren't actually your complicated med surg questions. It's actually like the what is the definition, what is the medical term for the right ear, or some stupid shit like that. So in your actual clinical practice, no one is going to ask you this, but it's important to know because real things happen, right? What is dependency versus codependency? Dependency is when the significant other or, a parent, so someone is doing things or making decisions for the other person. So the abuser is the dependent person. They are completely or partially dependent on the other person, the codependent person. They are completely or partially dependent on the independent person, the victim. You can't be half drunk all the time and do life. Somebody else has to do it for you so you can do your habit. That's a quote directly from Mark Clemec. And this is a demonstration of codependency in a person with alcoholism, because a person with functional alcoholism, if they start to get, even just the slightest bit dysfunctional, someone has to take care of them. Someone is buying them the alcohol. Someone is driving them, hopefully. Someone is taking care of their medical needs. And that person is the independent, because they're able to do it for the alcoholic, whom has become dependent on this person who is taking care of their needs. So some examples include, can you call your boss for me? Can you call my boss for me? Please? I'm so scared. I don't know how to do it on my own. Can you please call my boss? Can you buy me some alcohol, please? They already saw me in the store. I'm not allowed to go in. I got kicked out last week. I need it so bad. Can you pay this bill for me, please? I ran out of money, and I really need help. And what should I do? Because these patients are oftentimes incapable of making decisions on their own. I do want to say that I have seen a few questions on dependency and codependency, so it's worth noting that this is not something you should completely write over. You should have, a just idea of how to approach this. I also want to note that dependency and codependency exist as a disorder, and dependency, I have a note here, dependency can exist as a form of helplessness as well, and not necessarily a purposeful method of abuse, and it is oftentimes a result of trauma. There is such a thing as dependent personality disorder. People who suffer with this condition have difficulties with decision making, assuming responsibility in their life, and are extremely passive and submissive, and will often tolerate abuse just to not be left alone. This results from severe childhood trauma. It is not intentional or voluntary. Patients must be taught the confidence to provide for themselves. So dependency and codependency can be, abuse from the dependent person, or the dependency can come from someone who has dependency personality disorder and they're unable to make their own decisions as a result of trauma. It's just worth mentioning that you should be sensitive in your real life, but I doubt they will ever ask you this on the NCLEX. So codependency, when the significant other derives self-esteem for doing things or making decisions for their abuser. So if the abuser or the dependent person who is being taken care of has their caretaker, the codependent person, the independent person, that caretaker is going to get a great amount of self-esteem. They're going to feel so fucking good about themselves because they're taking a great job. They're doing a great job of taking care of their partner. And they think things such as, I must be a great partner because no one would do this for this dick, this asshole. Here I am, taking care of them and giving them a lavish life as much as I can. And I must be such a great partner for such an asshole that, won't fix our alcoholism. A good question I see quite frequently that makes me want to beat the shit out of people is, why doesn't she, he, they just leave the relationship? And this is because that person is so insecure that they would rather find confidence caring for their partner than caring for their safety needs. It is very hard to leave an abusive relationship. It is, the sense of safety that you get from someone telling you that they love you. It is the sense of security knowing that this person this person is your company. It is the sense of not knowing where to go. It may be a physical safety risk. It may be the psychological effects of isolation if this person is hurting you. So keep in mind that abuse is never as simple as black or white solutions. So dependency and codependency have a symbiotic yet pathological relationship. The dependent gets a free ride on the codependent, which is parasitism, and the codependent feels good doing stuff, taking care of the abuser or the dependent person. How do we treat this? 1, we have to teach the patient to set limits. The codependent person, the caretaker, needs to learn, no, I will not call your No, I will not call your boss for you. They need to learn to set limits. We need to teach them to enforce the limits. The dependents need to be confronted. The codependent or the independent person, the caretaker, needs to work on their self-esteem because they have to understand they are worth more than the help that they give their partner. They deserve to be helped too. They are not worthless without their partner, and they deserve to feel whole without being needed by someone else. Agree in advance what requests are allowed to be enforced. Alright, manipulation. Manipulation is when the abuser gets a significant other or, the parent, the child, to do other things or make decisions for them that are not in the best interest of the significant other or, the parent. So the difference between manipulation and what we were talking about with denial here is that manipulation is not in the best interest of the manipulator. So the nature of the act is dangerous and harmful to the manipulator or to the significant other. The difference between dependency and manipulation. For example, dependency would be a 48-year-old alcoholic asking her husband, who is of age, to buy alcohol for her. The husband complies because he feels the need to please his partner. This is morally wrong, but not, dangerous. Remember, we said that the codependent, the independent, the caretaker derives self-esteem from taking care of their dependent partner who needs to be taken care of because they're engaging or they're, stuck in a rock and a hard place in life and they're unable, have yet developed the skills to take care of themselves. Manipulation, on the other hand, is where the act that's being asked for is dangerous and harmful. For example, a 48-year-old alcoholic asks for her 16-year-old daughter to buy alcohol for her. This is illegal and this is harmful and dangerous. 16-year-olds should not be buying some fucking alcohol. What is the treatment for manipulation? We set limits and enforce them. Why? Because nobody likes being manipulated. People usually respond to manipulation as, I can't believe I was that fucking stupid to believe that. Nobody gets positive self-esteem from manipulation, so there's no need to foster self-esteem. Just set limits to enforce. The abuser will recognize and accept them. So this is Mark Clemek's Alcholism Part 1. Alright, let's talk about the fucking Part 2 of alcoholism. This is a med-surg and a mental health topic. So what the fuck is Wernicke or Korsakoff syndrome? Typically, Wernicke and Korsakoff are two separate disorders. The NCLEX, however, bundles these as one. Wernicke is an encephalopathy, and Korsakoff is psychosis. Wernicke's and Korsakoff tend to go together. The psychosis induced by vitamin B1 thiamine deficiency. Keep that in fucking mind. What do alcoholics need? They need vitamin B1 thiamine, because why else? They're going to be seeing shit and it's going to be your fucking problem afterwards. Give them thiamine. The primary symptoms are amnesia, memory loss. Wernicke-Korsakoff is a type of dementia, and just like other forms of dementia, it will affect their memory. And again, the memory loss is profound. It isn't loss of a few days, it's loss of entire decades. That's so goddamn depressing. So remember, we're talking about the psychosis. I have friends that are mentally unstable and they're currently getting drunk and smoking. Someone said that they're currently getting high as fuck, and I don't understand why I'm being notified of this. It's none of my business. Anyways, I put my phone on silent. God damn it. Okay, Wernicke's and Korsakoff. We're talking about the psychosis and encephalopathy. By the way, encephalopathy is the kind of the buildup of waste in the brain. It causes inflammation. So Wernicke's is a type of dementia. Remember, dementia is uncurable and the memory loss is profound. So what are we looking with Wernicke and Korsakoff of alcoholism? We're going to look at amnesia and confabulation, which is making up stories that they believe and make up for the gaps of their memory loss. I put honestly sane because I have ADHD and I be doing the same goddamn thing to try and not look insane. But the example was a patient who is a plumber in Ohio genuinely believes that they are Ronald Reagan's Secret Service member. What the fuck? This is what happens when you drink too much, y'all. What do we give them? Thiamine. Okay, how to deal with confabulation. Patient claims that they're going to a meeting with Barack Obama this morning. You, as the nurse, are going to redirect the patient to an activity he can do. Damn, you're going to talk to Barack Obama? Well, let's look at the news today. Maybe Barack Obama's on the news. Let's go figure that out, right? Let's go see what's on the news. That is redirecting. Characteristics of Wernicke and Korsakoff syndrome. It is preventable with what? Daily vitamin B1, that thiamine. It is arrestable with what? Vitamin B1, that thiamine. And it is irreversible. Your thiamine is not gonna fucking reverse it. It is irreversible, and 70% of it will kill brain cells. No dementias will ever improve. They only ever get worse. So what is the key to alcoholism and Wernicke's and Korsakoff? You give them vitamin B1. What is that called? Fucking thiamine. What is the treatment for alcoholism? Antabuse and Revia, also called disulfiram. I had to go back and check the actual generic names. I had to go back and check the generic names because Mark mentions in his older videos, he mentions the brand names, which are not used on the NCLEX anymore. So commit to memory disulfiram, what the fuck? Disulfiram, which is antabuse, and Revia, which is naltrexone, which is the antidote. So naltrexone is close enough to Narcan for you to remember it's an antidote. Antabuse or disulfiram is an alcohol deterrent. And from my understanding, it is awful. It is really fucking awful. It's a type of aversion therapy which punishes you, for engaging in that undesirable habit. So they create that negative association with, with the behavior, in this case, alcoholism. Antabuse and Revia, which is disulfiram, that alcohol deterrent, and naltrexone, the antidote. I swear to God, these people are still getting high. I need to put my phone on studying. Okay. Disulfiram and naltrexone have an onset of 2 weeks and remain in the system for 2 weeks. Why is that important? I have actually seen a question about this. We need to educate that the patient will feel effects in 2 weeks. It's not immediate, similar to all psych meds. And I'm pretty sure most meds in general, especially if they're PO, they're going to feel the effects in 2 weeks. And if they decide that they want to, get booty butt drunk at their homegirl's wedding, which is an awful idea, but you're not in control of that patient, they need to stop treatments 2 weeks ahead of time, because we said, again, it starts in 2 weeks and stays in the body for 2 weeks. And the way disulfiram works is it makes them violently ill, to the point it can also be kind of dangerous. If they're violently vomiting, that's an electrolyte imbalance. So again, if the patient will be out of function and would like to drink, the patient must be off the disulfiram for at least 2 weeks prior to the event, unless they want to avoid alcohol decay. It's up to them. All right, patients on disulfiram need to avoid all forms of alcohol to avoid physiological crisis, the vomiting, the nausea, and death. Sometimes I genuinely, that sounds terrifying, I'm not gonna lie. What do our patients need to avoid? Well, sometimes there are products with alcohol in them that, our patients will, with disulfiram that they're using for alcoholism, can be susceptible to. And we don't want these patients to die like dumbasses because they used a product that had alcohol in it. So what should the patient avoid? Let's teach them to avoid the following. Mouthwash, including alcohol-free. Cologne and perfume, because of the topical absorption. Aftershave, putting it on your skin leads to topical absorption. Elixirs, most over-the-counter liquid medicines. insect repellents, hand sanitizer, alcohol prep wipes. We should avoid swabbing the patients with these, by the way. Vanilla extract, which they cannot have cupcakes with unbaked icing. That's so fucking weird. And vinaigrettes, which the ones you put on salads. Again, the alcoholic patient, they need what? Vitamin B1, thiamine deficiency. What are the Wernicke and Korsakoff of alcohol, delirium, and encephalopathy? Gonna suffer from amnesia, profound memory loss, fucking decades worth of memory loss, and confabulation, where they're gonna make up stories and genuinely believe them to fill in the gaps of their memory. What are we gonna do? We're gonna redirect the patient where, patient's gonna say, I have an orgy with Barack Obama scheduled today. You're gonna say, damn, let's go watch the news while we wait for that to happen. So what are the characteristics of this encephalopathy, this syndrome of alcoholism? We're gonna give them vitamin B1. Why? Because it's preventable. We can prevent this syndrome with vitamin B1 or thiamine. It is arrestable. We can stop it from happening with that goddamn vitamin B1 and that thiamine. And this syndrome is irreversible. So that's why we prevent and arrest it. What are the treatments? Disulfiram and its antidote, naltrexone. This is a type of aversion therapy. They're gonna fucking hate their lives if they drink while on this. It's available for 2 weeks in the body and takes 2 weeks to work. So they will feel the effect of 2 weeks, and they need to stop treatment 2 weeks before deciding to drink their life away at Kevin's birthday party. And Kevin is only 10, so they shouldn't be drinking at Kevin's fucking birthday party. They need to avoid all forms of alcohol to avoid physiological consequences, including mouthwash, cologne, perfume, aftershave, most over-the-counter liquid medications, insect repellents, hand sanitizer, and alcohol prep pads, vanilla extract, and vinaigrettes, which are the ones you put on salads.